My name is Rebecca. I'm an emergency room nurse practitioner in New York, and I wanted to take a few minutes to address some of the allegations that have been circulating in a video on social media regarding the mistreatment of COVID patients in New York City. So I've been working in a New York hospital with COVID patients. The video that's been circulating was allegedly secondhand information put out by a nurse practitioner who has no experience with COVID, but who claimed that she was the voice of her friend who is working in a New York City hospital. So I think it's very important when you hear claims that are frightening, that are kind of harsh, to understand the broader context of what's been going on and to also verify that information, particularly when it's coming from someone who, by her own admission, has no experience with COVID. So, of course, as you all know, what we're dealing with here is a global pandemic, and this is a disease that's very, very new. It's less than 6 months old, and we don't have a ton of information about it. And that's very different than most of the conditions that we deal with on a daily basis. When you bring your loved one to the hospital, you trust that the doctors are usually going to know what to do because we have lots of research and data and information, decades, if not centuries of information of most diseases, and therefore we've developed treatments and protocols and how to handle them. And that's very different right now because with COVID, we don't have that. And so what we're doing is we're learning as we go, and sometimes the treatment protocols are changing, and there's a lot of research going on right now, but we have to adjust what we do based on the new information that we get. So I wanted to break down one by one some of the claims that were made and put them into context, and show you where there is some truth and some falsehoods to the claims. So regarding one claim that was made, that patients are getting intubated early and put on ventilators and they're not using CPAP and BiPAP. So initially this was true. We had information from China, from South Korea, from Italy, when the disease first started in the United States, and we were told that early intubation was going to be key to survival. And so we were intubating patients early as soon as they were showing signs of respiratory distress. And then as time went on, we realized that many patients who are intubated and go on the ventilator are unfortunately not doing well. And so we've adjusted our treatment protocols, and now we do use non-invasive measures like CPAP and BiPAP. What we also had to do was adjust those measures because the regular CPAP and BiPAP causes aerosolization of the virus, which means that anybody then caring for that patient is at extremely high risk of getting sick. And so now we've developed new sort of protocols for CPAP and BiPAP to minimize the risk of aerosolization, and so that the healthcare workers are put at less risk. So that's an example of something that was different a few weeks or a few months ago that we've changed with time as we learn and as we move through this. Another claim that was made: there are no family members around to advocate. So that's true. It's very, very unfortunate. But in order to mitigate the spread of disease, we had to severely limit who can come into the hospital. And it breaks our hearts that our patients are here without any family. But unfortunately, if we allowed them in, we would see massive amounts of more sick people out in the community. So that's one of the things that we've had to implement in order to try to slow down the spread of disease. It doesn't make any of us happy, but it is necessary in the current climate that we're dealing with. Another claim that was made: there's no hydroxychloroquine and azithromycin and various vitamin cocktails being given to the patients. So this is not true. Each hospital has developed its own protocol in how they're going to manage the patients medication-wise, and the reason for that is because we don't have a lot of good research and data to suggest that these medications work. We do have some data to suggest that there are some promising medications out there, but also these medications do have some serious side effects, and we don't want to put our patients at risk. So as with anything in medicine, we always have to weigh the risk versus benefit and make sure that we first do no harm, and that we're not giving our patients medications that could potentially be harmful, especially when we don't have good evidence that they're going to be beneficial. So there are many ongoing clinical trials right now for hydroxychloroquine with azithromycin, without azithromycin, with remdesivir, with other combinations of medications to see what will work. And hopefully it's our sincerest hope that we have some idea very, very soon to go forward with and to treat our patients with. But right now, we simply don't have that, and we're trying to mitigate any harm that we do to our patients. Another claim that was made: patients that are full code are not having full codes. The claim that a code was called and no one showed up. So I was not in that facility. I don't know what happened. I can't verify. But what I do know is that I have personally heard from ICU doctors who have told me that the rate of decompensation has been extremely rapid, and they've been running from code to code to code, intubating patients, stabilizing patients, getting them to the ICUs, one after another, hardly able to breathe in between. And so is it possible that a code was called and no one showed up because of lack of resources? It's possible. And if that were to happen, it's extremely devastating and unfortunate. But again, the reality is there's a pandemic with limited resources, and we are trying to do the best we can for our patients. To make it sound like it's being done out of spite or laziness is simply false, and it's very, very irresponsible. Another claim that's been made, staff is in the same PPE all shift. So it's been widely reported in the news, and everyone knows that there was major PPE shortages at one point. Thankfully, that has improved for most of us. But what that means is that there was a time where we had to seriously conserve PPE and sometimes wear the same PPE in multiple patient rooms, and nobody wanted that to be the case. No nurse, no healthcare provider, no hospital worker wants to be stuck in the same PPE all shift. I can tell you that it's extremely uncomfortable, and it also puts us at high risk for infection. But in the midst of the pandemic, where we have severe shortages, we are trying to do what we can with what we have. It's not that we want it to be the case. Suggesting that is very, very irresponsible. Another claim that was made, there are no rapid testing being done on patients. So as of right now, there is no reliable rapid test to do. Initially, when we first started having testing, the results took like a week to come back. Now with time, those tests have gotten much, much better, and we're seeing them come back sometimes in as little as 12 hours, which is a major, major improvement. But there are no reliable rapid tests to do. Another claim that was made, patients get trached if there are no vents. So this claim is false. It makes absolutely no sense. A trach is not an alternative to a vent. If someone is in respiratory distress and needs to be intubated and put on a ventilator, putting in a trach would be of absolutely no benefit to that patient. So this is a false claim. It doesn't make any sense. It shows a lack of understanding of what the benefit of a trach versus a vent is. Another claim that was made, nurses are killing people, nurses are leaving their patients to rot. It's patently false. Again, I don't know what happened in one particular hospital, but I can assure you that that is not happening where I work, and it's also not happening in the facilities of many, many of my friends and colleagues at other hospitals. I've checked up on patients on floors. I've called the nurses to check on patients. If nurses are going in, they're taking care of their patients. Friends of mine who work in ICU have told me personally that they are going in and out of the rooms, assessing their patients. We have whole teams going in and out of rooms to position the patients, put them on their stomachs, because we've learned that that often helps with their oxygen levels. So there are absolutely people going into room and checking on patients. So to accuse the nurses of being cold and acting like they don't care, again, I don't know what's going on in one particular hospital, but I can tell you that the nurses are carrying an incredible emotional baggage, and the psychological trauma that they're dealing with is unbelievable. To watch your community members, your family members, friends, colleagues, and patient after patient die of a disease when we have very little that we can do to treat is extremely traumatic. It's devastating. And so if a nurse acts cold and has to turn off their emotions to get through the shift, it's possible that that's the only coping mechanism that they can use to get through a shift and efficiently take care of their patients. I personally have had colleagues that have been sick, that have died. I have colleagues who have lost family members to this, and it's devastating. And to suggest that this is done out of malice, that we have malicious intent, that we're lazy, it's irresponsible, and it's very unfair to those of us that are putting our lives on the line going to take care of patients. If you don't want to call healthcare workers heroes, that's fine. None of us wants to be a hero. None of us signed up to work in this pandemic with limited resources. If we wanted to be heroes, we would have enlisted in the military. So I think it's very important to keep some of these things in mind and to keep the broader context in mind. And it's very easy to sit at home and pretend to act very outraged and to make claims that you're sounding the alarm about things and to accuse healthcare workers of murder, of neglect. It's easy to do that. What's not easy is to put on your PPE and walk into the front lines of battle with no ammunition, which is essentially what we're doing.